Hello everyone, today we'll discuss about subclinical hyperthyroidism. In the previous session we discussed on the management of pregnancy and hyperthyroidism. So our session for today will be subclinical hyperthyroidism. So we'll have an outline. The outline will see introduction. In this session we'll see introduction, classification, prevalence, etiology, natural history, clinical significance, diagnosis and treatment. So when you come to the introduction, subclinical hyperthyroidism is defined when there is low or undetectable TSH level with normal free T3 or T4 level. And somewhat subclinical hyperthyroidism is a misnomer because the diagnosis of subclinical hyperthyroidism is made by biochemical characteristics. Because of that, it's preferable to say mild thyroid dysfunction than subclinical hyperthyroidism. When you see the classification system for subclinical hyperthyroidism, based on the thyroid stimulating hormone level, subclinical hyperthyroidism is classified into two. Mild subclinical hyperthyroidism, when the TSH level is between 0.1 to 0.4 milli international unit per liter, and severe subclinical hyperthyroidism or grade 2 subclinical hyperthyroidism, when the TSH level is suppressed, that means when the level is less than 0.1 milli international unit per liter. So this is very important. The classification system is very important because the management option and the effects, that means the complication of subclinical hyperthyroidism, is usually different in the different classification system. That means it's different in both mild and severe subclinical hyperthyroidism. When you come to the prevalence of subclinical hyperthyroidism in adult population is depend on three factors: age, sex, and iodine intake. So in general, the prevalence of subclinical hyperthyroidism is around 0.7% in patient with severe subclinical hyperthyroidism and around 1.8% in patient with grade 1 or mild subclinical hyperthyroidism. But the prevalence may reach around 15% in older patients greater than 70 years of age, and around 20% in a patient taking high dose of thyroxine, exogenous thyroxine. When you see the etiology of subclinical hyperthyroidism can be classified into two, that is endogenous cause and exogenous cause. And from the endogenous cause, it could be persistent, it can be persistent or transient. The persistent cause: toxic multinuclear goiter, Graves' disease, toxic adenoma, and sometimes central hypoparathyroidism could be hypothyroidism could be the possible cause. In clinical practice and in old age, toxic multinuclear goiter is the most common cause of subclinical hyperthyroidism, followed by Graves' disease and toxic adenoma. When you see the transient cause, subacute thyroiditis, silent thyroiditis, postpartum thyroiditis, and euthyroid syndrome can be the possible cause of subclinical hyperthyroidism. When you see the exogenous cause of subclinical hyperthyroidism, iatrogenic overtreatment with levothyroxine, T4 is the most common cause of exogenous subclinical hyperthyroidism, and the other causes could be drug-induced thyroiditis like amiodarone and interferon alpha. Patient taking amiodarone will have high risk of iodine uptake. The patient will have high dose of iodine uptake because 37% of amiodarone by weight is iodine. That means if the patient takes, for example, 200 milligram of amiodarone per day, the patient will get 6 milligram of iodine per day. The other cause is iodine excess, exogenous iodine intake, and the other is steroid and dopamine therapy. Patient taking high dose of steroid, and for long periods, if the patient takes steroid for longer periods, the patient will have pituitary suppression, so TSH secretion will be low. When you see the natural history of subclinical hyperthyroidism is variable, and it is usually affected by the degree of TSH suppression and the etiology. But generally, overall, the progression rate of subclinical hyperthyroidism to overt hyperthyroidism is around 2 to 5%. That means 2 to 5% of patients with subclinical hyperthyroidism will progress to overt hyperthyroidism per year. But as I said, there are a lot of factors that will affect the progression. One is the degree of TSH suppression. As previously mentioned, patient having suppressed thyroid stimulating hormone level, that means less than 0.1 milli international per liter, will have high risk of progression than patient having grade 1 or mild subclinical hyperthyroidism. When you see the etiology as a clinical factor that will affect the progression rate, a patient having subclinical hyperthyroidism as a result of multineural arbiter and toxic adenoma will have high risk of progression to overt hyperthyroidism than patient having Graves' disease and other causes like thyroiditis, which will have high probability of spontaneous remission. And generally, around 50% of subclinical hyperthyroidism will spontaneous regression, or the patient will become euthyroid progressively. When you see the clinical significance of subclinical hyperthyroidism, the presence of low TSH level will have significant effect on the cardiovascular and musculoskeletal system. When you see the cardiovascular system, the patient will have a high risk of tachycardia, atrial fibrillation, increased left ventricular mass index, increased cardiac contractility, and there will be reduced heart rate variability. The effect of this subclinical hyperthyroidism is milder and less frequent when we are comparing with overt hyperthyroidism, and the risk was greater in a patient with severe subclinical hyperthyroidism than mild subclinical hyperthyroidism. When you see the effect on osteoporosis and fracture, the effect of subclinical hyperthyroidism on the bone is usually influenced by the duration of the disease and also the associated risk factor for bone loss and the degree of TSH separation. Generally, the effect of the risk of fracture patient having subclinical hyperthyroidism in adult is a matter of debate, but the risk of fracture is very high in a patient with postmenopausal age and not taking estrogen and biphosphonate. So when you see the changes induced by the thyroid hormone, what are the changes induced by the thyroid hormone on the bone? These changes usually as maximal in cortical bones like in the wrist, and it is very low in trabecular bone like spine, and this in the intermediate extent in trabecular and cortical bones like hip. When you come to the diagnostic modality, if you suspect hyperthyroidism, the first thing you have to do is you have to check the TSH level. When the TSH level is normal, you have to reconsider the other diagnosis and hyperthyroidism. But if the TSH level is low, you have to send the free T3 and free T4 level. So if both free T3 and free T4 level is elevated, you have to consider overt hyperthyroidism. If TSH level is low and T3 is low and T3 is normal and T4 is T4 is normal, and if T3 is elevated or high, you have to consider early hyperthyroidism or T3 thyrotoxicosis, isolated T3 thyrotoxicosis. But if TSH level is low, suppressed or low, and if both T3 and T4 level is normal, you have to consider the diagnosis of subclinical hyperthyroidism. So after you reach on subclinical hyperthyroidism, you have to investigate the patient more to reach on the possible cause of subclinical hyperthyroidism. So you have to send thyroid receptor antibody level and you have to do thyroid scan. On the thyroid receptor antibody level, if the thyroid receptor antibody level is elevated, so the probable cause of the subclinical hyperthyroidism will be Graves' disease. So if the thyroid receptor antibody is normal, so we have to see the thyroid scan results. If there is increased or normal radioactive iodine uptake, and if there is an increased uptake, for example, if there is diffuse uptake, you have to consider Graves as a cause. If there is localized distribution of tracers, you have to consider toxic nodular arbiter as a possible cause of subclinical hyperthyroidism. But if the thyroid scan, if there is decreased radioactive iodine uptake, so I have to send for thyroglobulin level to check whether the patient having an elevated thyroglobulin level or decreased thyroglobulin level. If there is an elevated thyroglobulin level, I have to consider transient thyroiditis as a possible causes. But if there is low or decreased thyroglobulin level, I have to consider exogenous thyroid hormone supplementation as a possible cause of subclinical hyperthyroidism. When it comes to the management option of subclinical hyperthyroidism, the aim of therapy is mainly to avoid potential side effects, and the others to restore the patient in the euthyroid state. So the management involves 3 steps. One is the confirmation, how to confirm whether the patient having subclinical hyperthyroidism. The other is assessment of the severity, whether the patient have mild or severe subclinical hyperthyroidism. and they have to determine the possible cost, because the management of the treatment of possible different causes of subclinical hyperthyroidism is different. The first, they have to assess for the potential complications, whether the patient develops cardiovascular complication or musculoskeletal complication or CNS complication. And the fifth, you have to evaluate for the necessity of the treatment, whether the patient needs treatment or not, because all patients with subclinical hyperthyroidism will not need treatment by definition. So the last principle of treatment is you have to select the most convenient or the most appropriate therapy for the patient. When you see the therapeutic strategy, usually varies depend on three factors. One is the cause, the other is the severity, and the third is the presence of associated comorbidity. So before you start on treatment, you have to be sure that the patient really have subclinical hyperthyroidism, so that if the patient has at high risk of complication from subclinical hyperthyroidism, you have to repeat the TSH level and free T4 level within 2 to 6 weeks. And for the patient, for other patients, like patient with young age and has no associated comorbidities or risk factors, you have to check, document that subclinical hyperthyroidism is a persistent problem by repeating the serum TSH level at 3 to 6 months. So the principle of treatment usually depends on three factors. As I said, one is the cause, the other is the severity, and the last is actually the associated presence or absence of associated comorbidities. So in all the patients, if the TSH level is in suppressed state, that means less than 0.1 milli international, you have to treat. And if the patient is in the mild subclinical hyperthyroidism, considering treatment will benefit the patient. In a patient, young age patient, less than 65 years of age with associated comorbidities, if the patient is in the severe subclinical hyperthyroidism, treatment is recommended. And if the patient is in mild subclinical hyperthyroidism, considered treatment will benefit the patient. But if the patient age is less than 65 years of age, if the patient is asymptomatic, no other risk factors or comorbidities, if the patient's subclinical hyperthyroidism is confirmed by repeating the TSH and T4 level within 3 to 6 months, considered treatment will benefit in patient having severe subclinical hyperthyroidism, and observation is recommended in mild subclinical hyperthyroidism. When it comes to the last session, election of the treatment option, the armamentarium or the treatment option for the subclinical hyperthyroidism and overt hyperthyroidism is almost similar. So we will use antithyroid drug, surgery, and radioactive iodine therapy as a possible treatment option. So thionamides or antithyroid drugs are used in mild Graves' disease in young patients, and to make patients like toxic multi-marrogator and single hyperfunctioning nodule patient to make euthyroid before surgery and radioiodine therapy. Surgery is usually recommended in young individuals with toxic adenoma and toxic multi-nodal goiter, and in Graves' disease if medical therapy fails. Radioactive iodine is reserved for old patients with multi-nodal goiter, which are unfit for surgery, and for cardiac patients with associated cardiac disease, which is not candidate for surgery.